This is really an honor and a privilege for me to introduce a colleague, a former colleague, and a research collaborator. Dr. Naik is one of the leaders in implementation science in the country. He is currently professor and associate dean for Learning Health System and chair of the Department of Management, Policy, and Community Health at the University of Texas School of Public Health. He is also the Nancy P. and Vincent F. Guinee Distinguished Chair and Director of the UTHealth Consortium on Aging in Houston, Texas. Dr. Naik serves as co-director of the Southeast Texas Geriatrics Workforce Enhancement Program, a Health Resources and Services Administration HRSA UO1 supported program, and he is a senior investigator at the Houston Veterans Administration Center for Innovations in Quality, Effectiveness, and Safety. Integrating these roles, his research program uses population health systems and interventions to improve the healthcare decisions and outcomes of older adults with complex and multimorbid conditions. In particular, he is a co-developer of a national collaboration for patient priorities care, an innovative model of multimorbid care. His research program includes randomized clinical trials, implementation science studies, and primary data collection with continuous research funding since 2006. These studies have produced over 200 peer-reviewed manuscripts, commentaries, and book chapters. And Dr. Naik is going to talk today about digital health and how it impacts the patient experience. And I'm really excited. And I want to thank you, Aanand, for being able to and willing to give this talk today.
I think we're set. Can you hear me? Yes, okay. Well, I want to thank Dr. Berger for that very generous introduction and the invitation to present to the Downstate faculty, staff, students, and a topic that's, you sort of proposed this topic, and I was like, well, I don't exactly have a presentation for this, but I thought it was really an interesting title, an appropriate topic for the day as we are hopefully emerging out of COVID. But still, I think very much in a digital era, and how do we think about patient-centered care in ways that are actually meaningful and empirically important, not just a marketing slogan. So as you will see, Dr. Berg and I have had collaborated for quite a while, and I found a way to work some of those collaborations into the presentation. So excited about that. So I don't have any commercial disclosures at the current time. Learning objectives here is to elaborate the key features of patient experience, which is a concept, and how it differs from sort of global satisfaction or patient satisfaction. And then to describe the association between a well-developed patient experience measure, patient experience, and health outcomes. And then identify the challenges of providing patient-centered care in a telemedicine era. And then one intriguing application that we have developed. So starting, I think big picture, 10,000 foot, what is quality? When I sort of ask students, how do you describe quality? And sometimes it's, it's like that old Potter Stewart comment about pornography. I know it when I see it. So, quality is I know it when I see it. And I say, as a health services researcher, I was like, no, that's not the right answer. If you can't measure, define something, you can never really change it or improve it. And, it's nice that the IOM at the turn of the century actually had this crossing the quality chasm and defined 6 dimensions of quality. And it's really an established framework for understanding it. I think everyone understands the first 2 dimensions, effectiveness and safety. When you think about quality, you think really almost sometimes exclusively in terms of effectiveness and safety. And for many years, I was heavily VA, and I would ask people, okay, well, what was that thing when you heard all that bad news about the VA in 2017, 2018? What was all that about? And people who don't know that much about it, oh, well, it was just not an effective system or not a safe system. And I'd be like, no, actually, the RAND organization did an external review and found it to be equally effective and safe as most other health systems. Its problems were actually in other areas of other dimensions of quality. So 2 other dimensions are efficiency and equity. But the two areas that the VA had trouble in 2017, 2018 are the last two dimensions, which is timeliness and patient-centeredness. And how important is patient-centeredness? Well, when you got a system that was so poor in timing and so poor in its veteran responsiveness, it impacted everyone's perceptions of the VA system, that they thought, oh, it's just a terrible, from an effectiveness safety perspective, when no, it was actually quite good on that. It was just bad in timeliness and patient-centeredness, and that really tarnished the whole reputation of the system. So that's where really thinking about all dimensions as equally important, and not really one is instrumental. Why is patient-centeredness important? It's not important because it makes effectiveness better or safety better. It's important because it in and of itself is something that people judge the quality of a service or a system around. So I want to talk today about the dimensions that really come more from the patient's perspective. That I think both of these dimensions you can also measure from an objective or a third party or a clinician's perspective, but these are the two measures that really require patient involvement and measurement. And of course, the first one is timeliness, providing the right care at the right time, reducing waits and harmful delays. And that's a whole nother talk for another time. So today we're going to really focus on patient-centeredness, which is being respectful of and responsive to individuals' preferences and needs. And that's sort of what the patient experience is about, being respectful and responsive to the patient's experience of care, their preferences and needs. And then the second aspect of it is really designing and guiding care that's guided by patients' goals. Here's another visualization of how to think about the patient's perspective on healthcare quality, specifically around timeliness and patient-centeredness. And within patient-centeredness, we're going to talk about patient's experience of care and patient-defined goals of care. So let's drill down to patient experience. So, I think that when this idea first came around, there's lots of eyes rolling. There's still probably lots of eyes rolling around this. It's these marketing slogans like, now healthcare is a consumer product, and consumerization of healthcare is what we need to know, and we need to get on the list of high satisfaction. That's sort of a lot of buzz, especially around 2010, 2012, lots of buzz around this issue. And so you might ask, why is it important to measure this? What does all this mean other than getting on some billboard or, getting more people through the front door? Why does satisfaction matter? What does it predict? And I think the way to ask that question scientifically is there a relationship between satisfaction and things that really matter? So healthcare utilization, expenditures, or even mortality. And can we measure satisfaction? So, early on, there was a set of measures that had been developed. These are the first set of measures called the CAHPS measures. And we're going to get into this a little bit more, but this is sort of a global 5-item measure. And then you might look at some outcome data around it. So there's a number of large healthcare utilization databases, and MIPS is one example. It's a Medicare expenditure survey. So really one of the first, I think, high publicity, well-regarded studies in this area was one by Josh Fenton in Archives of Internal Medicine. That's now JAMA Internal Medicine in 2012. And you really looked at the CAHPS satisfaction measure, this global measure. So this is the CAHPS measure. There's a STEM asked, how often in the past 12 months did the patient's physician or other healthcare providers perform the following? Did your provider listen carefully, explain things in a way that was easy to understand, showed respect for what you had to say, spent enough time with you? Those are 4 measures. And the 5th measure was just a global measure of satisfaction. But it was asked in the sense of how often in the past 12 months did you feel like your provider did these things? And then we sort of rated the global one from 0 to 10. So Fenton et al. Sort of looked at this, and they did a prospective study really across 7-8 years, 50,000 plus patients. And the predictor variable was this global satisfaction measure. And the outcome variable was various outcomes within MIPS, especially healthcare utilization, costs, and mortality data. And what they try to do is look at year 2 ED visits, inpatient admissions, and mortality from year 2 to year 5, also year 2 total and prescription cost expenditures, and they looked at year 1 ratings of satisfaction. So it's a somewhat prospective looking cross-sectional database. So here's some outcomes, and I'm going to get into this a little bit more. I know it's probably a little technical here, but the key thing here is if you are more satisfied, then look at the drug expenditures. If you were more satisfied, you were up at 9%, had 9% higher prescription drug costs. If you were more satisfied, you had about 8.8% higher healthcare utilization. You had about 1 to 2% higher inpatient admissions, and maybe you had a decrease of 1% of ED visits, but even that crossed zero, so it was non-significant. So if anything, higher satisfaction versus less satisfaction was predicting more drug use, more healthcare expenditures, and more inpatient admissions. And here's a real kicker. 1 year satisfaction was actually predicting higher mortality. And even if you excluded the most sick, so the people who rated their health as poor and had 3 or more chronic conditions, in fact, you're more likely to have higher satisfaction predicting death if you excluded this sort of really sick population. So if anything, the take home of this is more satisfaction was predicting more mortality and more use, more care. And so that was a bit of publicity that came across from this study, higher satisfaction associated with lower ED use, but at higher inpatient use, higher total and pharmacy cost, and a 25 higher odds of mortality, and actually a 40% higher for the sicker multimorbid population. So, are we saying satisfaction kills people? No, but I think what the point was satisfaction might be leading to higher cost of care, higher cost of care, but it was unclear if this care was better. So, building on this, you might ask, what would you measure, to really kind of look at what difference does all this make? So you really want to look at something that's more than adherence to process of care measures, because that's somewhat of what a lot of satisfaction measures we're looking at, is how satisfied are you that you were getting the best diabetes care, or how satisfied were you that you were getting the best post-surgical care. So the clinicians among us might say, well, how many of our patients can actually judge how well that post-surgical care was, or how well that diabetes care? I mean, they don't really know evidence-based practices. That's not really the best place for a patient to measure. And honestly, the better thing for a patient to really think about and measure is their subjective experiences of care, and often the interpersonal care experiences that they have. So that's the kinds of measures you want them thinking about is, what is their rating of their communication with their nurses? What is their rating of the pain relief that they're experiencing? What is their rating of the timeliness of the assistance that they're receiving? So things that are much more about subjective patient reporting of an experience or an interaction. And those seem to correlate with satisfaction and might actually better correlate with outcomes. And there's a really nice short essay in the New England Journal from 2013 by Mannery et al. That actually explains this nicely and gives some concepts here. And what's really said is, you want to get to patient experience measures that are about patient reports, that are specific accounts of what happened. Did you receive information about your treatment? Not did you receive the best scientific data within that information, but just did you receive the information you felt like you needed to help you make a decision? Or in a patient evaluation, that's your specific experience of the patient's experience with care. How would you rate the information you received for your treatment? Those sorts of things. So here's some very specific types of measures. This is in the HCAHPS measure. So this is one of the patient experience measures that's being used even today. That's the Hospital Consumer Assessment of Healthcare Providers and Systems. And this is what CMS Medicare uses for rating the quality of hospital care or post-acute care. And it's really, care about what, during your hospital stay, how often did the nurses explain things in ways that you could understand? Before giving you any new medication, how often did the hospital staff describe possible side effects in a way that you could understand? During this hospital stay, did you get the information in writing about what your symptoms or health problems to look at after you left the hospital? So these don't take scientific or technical expertise. This is more, did you get the information you needed for you to feel more informed and for you to be a participant in your care? So if we go back and we look at, so in that Mannery article, they'll actually go back and look at that Josh Fenton article. At the time, it was sort of the classic article looking at its satisfaction and outcomes. And they said, we have some criticisms of that approach. And they didn't really look at a specific event or a visit. They looked at global ratings of satisfaction. And it did not focus on specific interactions. They looked at all providers or the overall level of care, the overall level of coordination. I think there's one item about a specific clinician, but a lot of them are about general items, and the timeliness of measurement. So the best HCAP measures are asked almost like within or less than 6 weeks of discharge, not in the past 12 months, which is what the original measures asked about. And they didn't really do enough statistical adjustment for any potential confounding. So that's, I think, a technical critique of that work. And there's often not consistency of one satisfaction measure or another. This is certainly true in 2013. And I think we've come a long way in terms of that measurement. So sort of revisiting that cost of satisfaction study, the critique was it used a composite measure of 5 very global satisfaction ratings. It was the past 12 months experience. The outcome was often months or years later, and there was minimal adjustment for confounding. So here's the bottom line on patient experience measures. You need to focus on a specific encounter, event, or visit. You need to measure a perception of specific interactions, keep the measurement timely, and do the appropriate amount of risk adjustment as necessary. If you follow these principles, then you can actually have more valid patient experience measures and ones that actually do predict meaningful outcomes of care. So let's move forward. So that was, let's say that was 2013 when the patient experience movement was really getting going, and the best we started to understand the principles of patient experience measurement and how to go about doing it. And then I think CMS got more involved. They really wanted greater use of digital health, and they wanted patients to be more engaged with digital health. So this is sort of, I think, the first forays into trying to create patient-centered digital health tools and efforts. And this was sort of translated in terms of some regulations called meaningful use requirements. And these were, again, requirements by CMS. There was some financial incentives to, initially, the first meaningful use was trying to get health systems and clinics and hospitals to start to adopt electronic health records. So if you're as tortured by EMRs as the rest of us, you can blame meaningful use and CMS for those initial incentives. And they encouraged direct use by patients of patient portals and other ways for them to get involved in their care. And so you saw really in the early 2000s, slow efforts to sort of take some of this on. There was more engagement around, let's say, medication refills and maybe some test results, but less so in terms of, let's say, patient involvement in secure messages. That's much more common today than it was in, let's say, 2010, so to speak. And in 2014, CMS tried to really get patients even more involved in the patient portal effort, and they created some incentives specifically targeting the development of patient portals. And the truth is that even with those incentives, there wasn't that much uptake. By mid-decade, we're still only looking at 30 to maybe at the most 60% use and satisfaction with a number of different ways in which patients could engage with digital health, patient portals, and EMRs. And so we kind of went along like that for a few more years, and then this thing called COVID-19, of course, came along and transformed telemedicine and transformed the way that all of us engage with digital health. And so we saw widespread adoption of digital and video technology beyond niche clinical uses. And of course, CMS quickly got involved and expanded billing and coding options. And I think for many ways, building the business case for telemedicine such that it's very clear today. And I specifically recall running a geriatrics clinic in the midst of the pandemic. I couldn't get any providers to do anything on telehealth or e-visits or anything like that. And then within 2 months, 3 months, everyone was doing it because that was the only way we could stay in business. And I think, I don't think we're likely to reverse course. I think you'll see some minor coming back in what CMS is willing to pay for, but for the most part, patients and clinicians see the benefits of it and the business case for it. And so I don't think it's going away. And clearly there's lots of business opportunities, especially if you keep digital health and patient portals telemedicine as it relates to both the inpatient stay, the outpatient, the ER, prescription use. There's money to be made there across all these top 10 chronic conditions. That's the percentage in which there's some use of digital health currently. There's some evidence that overall satisfaction rates with general care, ease of access to the doctor, not as excessive out-of-pocket costs. So in general, there's great interest in this. I don't think it's going away. So let's drill down on this. So we're starting to now get some of the first bits of evidence around what is our experience with telemedicine and telehealth during the COVID-19 pandemic. And there's certainly some positive perceptions of telemedicine. There's elimination of commute times. And this might seem trivial, but this comes really stark for me as a geriatrician. When you really ask your patients what it takes, they often say it's a half-day adventure from, getting up and getting ready. And there's always equipment, and there's always a ride to be had, someone to drive them, a family member to bring along. There's parking. It takes them a lot longer to get out of the car and walk up to a clinic, sit and wait. It's a half-day adventure for my patients, and I suspect even for the young and fit, it's not. I think they're very happy to get rid of their commute times for care. There's some lower access of costs and anxiety around it, cost and anxiety related to parking, to hassles, to lost time at work, et cetera. There are some positive physician-clinician interactions. It's facilitated some quick responses from questions, concerns. Many patients feel like they get longer, more thorough visits, less rushed. I think on the complaints, you sort of see some things in the opposite direction as well, but there's certainly opportunities for feeling like there's more engagement. Of course, there's some negative perceptions of telemedicine as well. Sometimes they feel like the communication itself is not as good of a technology, especially if you have a poor digital connection, poor technology, you don't have the best web camera, that gets in the way. It sometimes causes delays in administrative tasks or referrals. You're in the doctor's office, it's easy to just walk down to radiology to get something taken care of, or you get the nurse in the doctor's office to fill out the referral form. So that's a little bit harder when you're doing it through telemedicine. There's some decreased human connection, which makes some types of encounters difficult, the ones that are a bit more emotional. The ones that are delivering news is a little bit harder. I did do some palliative care telemedicine over the pandemic. It's not ideal, and it makes that a little bit more fraught. Inability to complete a physical examination, obviously lab draws, medications, and some patients feel like they have a less thorough and more rushed visit. Yeah, the bottom line here is I think that most patients, and as I would say us as clinicians, don't desire to replace inpatient visits, but we think that telemedicine can augment the in-person experience. So let's talk about some patient safety concepts and how telemedicine and digital health impacts ambulatory or patient safety. And so these are the domains in which safety could be impacted with anything we do: medication management, diagnostic errors, care transitions, referrals, culture, and testing. And here's some strategies for potentially mitigating vulnerabilities. So communication, health technology, care teams, patient engagement, organizational approaches, measurement. The ones that are italicized, communication, care teams, patient engagement, these are the ones that are a little bit more tricky and more vulnerable in a telemedicine environment. So here's some specific examples. So the impact on diagnostic errors. So, we tend to see lower quality history taking and physical exams, especially when we're talking about poor quality or audio only visits or communication technologies. In those cases, you don't get as good histories and you don't get any physical or very few physical exam findings. There's a reliance on the patient as the data collector. So that can cause all sorts of errors, especially with vital signs or describing physical exam or showing you a physical exam. Increased cognitive load on clinicians. So you've got to keep more tasks in your head. You can't rely on other team members. You can't rely on other available technology that's on hand. So that puts a little bit more of a cognitive load on clinicians, and that, of course, makes you more vulnerable to error. And then there's changes in the way that diagnostic workups and decision-making occur that can impact diagnostic errors. There's also an impact on medication safety. So again, patient-provider communication challenges, especially reduced effectiveness of medication reconciliation, a lack of access to specialized team members. So there's fewer pharmacists sometimes, unless they're also part of the telemedicine portal, but it's not as easy. An increased reliance on patients' literacy, language, technology skills, because you don't have extra tools, you're relying on them. So it's not only your cognitive load, but it's their cognitive load, literacy, language, technology skills. And changing the availability of tools to ensure adequate medication review overall. So how do we try to address these issues? How do we improve safety in the telemedicine era? We need to think about systematically measuring safety outcomes and in use of increased reporting of safety incidents, especially tools that can be embedded in an EMR around safety, getting clinicians to use incident reporting systems, making those reporting systems much easier so it's not a lot of work and a lot of load on us. Identify who are the higher risk patients and what are the higher risk clinical scenarios. So if you think about older patients, comorbid patients, cognitively impaired patients, if you think about situations that are more fraught, care transitions, emergency room settings, these are the areas in which you have the greatest risk for safety errors in a telemedicine era. Identify and support best practices to ensure equal access to safe telemedicine. Get your health system to invest in higher quality video. Increasingly we see better technology around remote collection of data. So remote vital sign collecting, having the patient hook up to themselves to remote monitoring devices. Even some types of physical exams or other exams can be done remotely. This technology will only get better and better over time, and ways to sort of augment this approach. So getting back to my conceptual model here of patient-centeredness, I think of this as really two steps. The first step is really, honoring and being aware of the patient experience. We really just showed that in the early measurement in the early 2010s, and as that measurement has gotten a bit better, and being mindful of the patient experience, but then really creating tools that get at the outcomes that patients care about the most, focusing on those outcomes, engaging them, understanding what patients need so that they are better able to help us in the process of identifying potential warning signs, identifying potential adverse outcomes before they occur, and improving and getting patients to the outcomes that they care about the most. So that's really at the heart of patient-centered care. So I'm going to, the last piece of this presentation is really describing one type of a patient-centered intervention that we've developed. And it's really around telehealth that I think done at a nice way. And this is sort of the journey of creating a digital app that looks at colorectal postoperative outcomes of care. And what the app tried to do is really create a meaningful, effective patient engagement in the postoperative care experience, try to create something that was more patient-centered, even patient-driven, in terms of them being the sentinels for early warning alert systems when they're at home, for potential readmissions, that we really used evidence. It was very empirically grounded, and we created an approach that was at first more analog, but we allowed technology to sort of take it to the next level. We've gotten a little bit of funding from the VA. This is something that Dr. Berger and I have been doing for, I look back at the dates, it's been a decade, I think, Dr. Berger. So we were focused around colorectal surgery and really around readmissions. And we noted that there was a 10 to 13 kind of percent readmission rate. And we wanted to sort of understand this a little bit better. And we did this by starting by doing a systematic review and meta-analysis. And we were really looking at what were the causes of readmission following colorectal surgery. And we took again, a classic systematic review and meta-analysis approach. And Dr. Berger and I mentored a surgery resident at the time, Linda Lee, who was doing a research sabbatical. She did a really nice systematic review, and she identified not only the rates of readmission, but the key causes, the key conditions that she could identify from the literature, and then some pooled estimates on to what degree did that particular condition lead to the readmission. So this isn't rocket science. You guys could guess what these things are: ostomy, leaks, bleeding, respiratory symptoms, PE, for example, dehydration, infections, abscesses, ileus, small bowel obstruction, et cetera. And that was sort of a nice way to show the evidence. These are the conditions that cause readmissions. So what we did next was we did another study at the same time. We actually got together a Delphi expert panel. This was an expert panel of surgeons, colorectal surgeons, general surgeons who did a lot of colorectal surgery, surgical oncologists who were doing abdominal surgeries. And we had them convene. We had them first come to a national meeting and meet in person. And then we did successive rounds of expert panel by actually asynchronously by email. And then we closed it off with a virtual teleconference. And what we did is we gave them the evidence from that systematic review. And we showed them these were the conditions that the literature say are the reasons why patients get readmitted. Now we want you to tell us, what do they say to you when they're either calling your office, when they come to see you in clinic, when they come to see you in the emergency care or the emergency room? What are the symptoms and signs that they're presenting for those conditions? So I looked at the appendix on this and I noticed it wasn't so straightforward. We didn't get these straightforward answers. We got lots of answers and it took this many rounds to kind of get to consensus. But we really got to consensus. And the first two are the things that we would describe as emergencies, chest pain and shortness of breath. This isn't you sit at home and wait a week to come back in, see how things are going. This is, either come into the emergency room now or call us back first thing in the morning if this doesn't get better, and that sort of thing. And then we had another set of sort of signs or symptoms, and these were the cardinal signs or symptoms of those conditions that predict readmission. And we wanted to word it in a way that both the clinicians in the office understand these words. When someone comes in and they say they're having abdominal swelling, they're having vomiting, we know that this is something to pay attention to because it's related to one of those conditions that cause readmission. So this is a really nice study and paper that we got into the Journal of the American College of Surgeons that really showed these cardinal signs or symptoms. So then the next thing we did was sort of take that to the next level, is then go from sort of doctor and nurse speak to now we went to patient speak. And how do we get the patients to think about those signs or symptoms in ways and words that they would use? And how would we construct this into a patient format, a patient-friendly format that they could use and that we could communicate within kind of, the classic green, yellow, red zones. And this is the green zone is you're doing well, you don't have anything to worry about, keep doing what you're doing. The yellow zone is, yeah, let's pay attention to that. Maybe you need to call me back tomorrow or in a couple of days, or maybe you need to come in and see us in clinic, versus the red zone, which is you need to come to the emergency room now. This is pretty serious, or even call 911. And really in terms of kind of patient speak, we sort of work this into a triage flow. How would patients think about this? Who would they call? What would the nurse say to them? How do we triage them? And that sort of a workflow, and kind of made that into a process. And this is a nice publication as well that showed some of these informatics tools that we developed, and that went into the Journal of the American Medical Informatics Association. We did do sort of an analog clinical intervention that we did in the hospital, but what I wanted to show you here is actually a digital solution that we developed as well, which is we worked with a company and they sort of took the things that we had been developing and put it into an app. And this would be a daily tracker. So we asked patients on a daily basis, pick a time of the day, and just to walk through it. And if you're not having any symptoms, it'd be fine, and you'd be in the green zone, everything's fine. But if it was a yellow zone, then it was, call the office and let them know, and we'll keep track on it. And if it's a red zone, then it's an alert to call the emergency room or call the nurse to triage for potentially to go to the emergency room. And we then took that we actually trialed it in a very kind of high risk. It was a kind of a tax-funded hospital system, kind of really a highly vulnerable patient population. And we found that there was generally good use, even though they were low resource, didn't always have a smartphone. They were tended to want to use it. They either found reassurance in using it, or could use it for the most part. Then we also got some things where they had trouble using it and ways to kind of improve on the process. So it's sort of an example of how we started from a basic clinical problem we all face, we all understand, how we transform that from a very patient-driven, empirically based, but patient-driven approach to identify the kind of signs or symptoms that the patients would alert the clinical team to, and then created a digital app that was very much written and done in a way that patients can understand. So I want to close on just some of my recommendations here for patient-centered care in the telemedicine era. So use telehealth, telemedicine as an adjunct. I think that's right, as an adjunct to in-person visits, not as a replacement. Now, again, I'm a geriatrician. I have certain patient populations that can't get into CS. They are homebound, and that's tough. And we still try to create some house calls programs that try to have some in-person. But there are a few examples there where strictly a telemedicine approach is what you need. But I think for the most part, think of telemedicine as an adjunct. It adds to the patient, the in-person visit. Immediate access to certain things like after a visit, summaries, make that available online very quickly after a visit. Pending lab orders, appointment dates, make all that very user-friendly. You might actually get patients to call your office less if you have these things up and easy for them to use. Tools must maintain a closed loop verbal communication and written communication. This is classic from the patient communication literature. So create tools that make communication a little bit seamless, that create closed loops, and that's really what our tool did. If I gave the tool to communication scientists, they said, well, your tool worked because it was actually a closed loop communication tool that was very much patient enabled. It was done in their language and their understanding, but allowed them to close the loop around things that were important clinically. And then cultivate patient-clinician relationships during your inpatient visits that then support telemedicine visits. So sometimes the things that people talk about that are more difficult in telemedicine, if you establish good patient-clinician relationships in person and you pay attention to the patient experience, that will then help you when it's a little bit harder to have those experiences across telemedicine and digital tools. Thank you. Questions?
So, Chris, can you shift this so we can get questions?
Should I stop sharing?
So, Dr. Lewis, Chris, can you give Dr. Lewis the ability to speak, or I can read his questions? Okay. Aanand, can you see the comment?
Yeah, I can see it. So I guess I had a follow-up about what he means by in vivo. So when you can't get access to a patient, and that's what happened during the pandemic. This is our only method of actually touching and engaging with our patients. So in that sense, it was a vital activity. I think what I would say is the same principles that make for a meaningful in-person visit you mean by more in natural settings. I guess I don't fully understand the question.
Let's go then to Dr. Lester's question, and maybe we can give Dr. Lewis access to actually speak.
Yeah.
Dr. Can you comment on ways to ensure digital health use in high-risk communities? And have you found adverse usage related to social determinants of health?
Yeah, so what people often say is that technology just sort of exacerbated health disparities, social disparities. The people with the most means had more access to technology, better technology, had the understanding and the know-how. So yeah, I think digital health only probably made that worse, but I think it's incumbent on us to kind of use digital health as a tool around social determinants. So I think in some ways the hospital at home movement has actually become more viable and more realistic, more feasible with the use of digital health and digital tools, because then it's not reliant on a number of different healthcare professionals going out to someone's house. That's expensive. You've got to bring a lot of equipment with you. That's expensive. And that's difficult to do. So if you can bring digital tools that are less expensive and that can, maybe link in, maybe it's just the nurse who goes out, but the nurse can use a higher quality digital tool to bring in the surgeon, and they can do, the nurse can do the exam or even help with some visualization of the wound site or the symptoms, and then you have the expert who doesn't have to come all the way to the house. So that's creative ways in which we've used tools to get at harder to reach and more vulnerable populations, higher risk communities. So I think if we're smart and deliberate about using the tools to improve access and improve the patient's experience of care, I think that we can actually get at more higher risk communities. I think this is also a lower cost way of bringing in home and community services, social services organizations, and making them, sometimes where's the line, where do you draw the line of what is a healthcare intervention versus what is a social care intervention? Especially in my patient population, that gets really blurred. And I think technology can help the social services people feel less off-put or get them more engaged and more involved.
So Anand, first of all, I want to thank you for showing people that I did something before I was a hospital administrator. So thank you for highlighting that work that we did. One of the things you were talking about with patient portals. Patient portals, however, are discontinuous forms of communication, right? So you go into the portal, you send a message to your provider, and then you have to wait hours to get the message back. You have to log back into the portal. So usage has sort of leveled off, and some people don't like using the portals. Can you tell us your experience in portals versus, which is a discontinuous form of communication, versus SMS and continuous form of communication, sort of around the app that we were working on?
Yeah, the app we were working on is a perfect example of this. That's probably why you asked the question that way. So, when you, and I'm going to pick on the surgeons, Dr. Berger, but I think the surgeons in particular were notorious for saying, like, I don't want you to tell the nurse. I want the patient to tell me. If they're having symptoms, I want them to come and let me know about it. And I think it's just the personal responsibility a lot of surgeons had with their patients and the surgery that they performed. But just think about that. If you had every patient that you recently had surgery on contacting you directly, let's say to your text on a regular basis, no matter what you were doing, that's just ridiculous. Like, you wouldn't get any work done. So I think having always direct synchronous communication, while that's direct and it seems like you can just quickly resolve an issue, you can't escape from it. It's always on, and you don't always get the most thoughtful response back from a synchronous. And so I think we have to be thoughtful and careful about what we want synchronously and what we want asynchronously. And I think sometimes we also have to discipline our patients not to get them to think they can always just call us and we're always available 24/7 on a synchronous platform. So sort of creating expectations around the degree of availability and communication, I think, is an important principle to avoid burnout and to really provide better care sometimes. So setting some ground rules, and that those ground rules apply, and that's how we can use asynchronous communication. And just as a team, to be mindful of what is better handled asynchronously and what is better handled synchronously. Maybe there's certain things that you absolutely need to tell me about right away because it's an emergency, or there are certain times of the day that I'm going to be available for synchronous communication, and that's the time you try to catch me. And other times, asynchronous, I'll get to it when I can. Or some of the benefits of asynchronous communication is that it doesn't have to be one person who responds. It could be any number of the people on the team, and it's whoever has the available time to actually go to the portal and answer the question or address the concern. So that's the way. Some of this is common sense, but I think there's been tools and principles that have been created around what's better handled synchronously versus asynchronously.
So I think what Dr. Lewis is getting at is that the in the office or in the hospital or in the facility is what he's referring to as an unnatural or in vitro setting, comparing it to being at home, which is a more natural setting, which is an advantage of telehealth, right? So
Yeah.
the intimidation of coming to the big house and the ivory tower and
Yep.
dealing with sterile hospital rooms. So that's certainly an advantage of telehealth. But how do you balance that against the downside of telehealth?
Yeah, no, I think that that's perfect. So I think we often use that sort of white coat phenomenon, right? So, the blood pressure is always different in the office. And so we definitely, again, use my geriatrics experiences. You get telemedicine provided us with a version of house calls. I could actually see what the house looked like. I could actually see how all the extra medications that were just laying around. The patient didn't make themselves up. They are actually in their regular environment. So all the things you said, the in vivo, gives you a really much better feel of what the patient is actually doing and what their life actually looks like, how they're actually functioning. You get a better sense of that. I think people sometimes cut some corners because it's so informal. So I think some of the things that we do in the office setting that's a little bit more formal, and it forces us to make, I found I make the harder decisions better when it's in person. We kind of put off hard decisions when it's done on telemedicine, or it's some of this more in vivo.
Right.
So it sort of forces us, and sometimes that's also because you're there with your other clinicians, and you're sort of
So,
all sort of powwowing over the issue.
so we're doing a pilot with someone Tim Garson,
Yeah.
grand aids on post discharge, and it's sort of uh, a mashup, I guess, of telehealth and in person. So we're sending aides to the hospitals for to the home for patients who've been discharged from the hospital, and then the aide helps to communicate to a provider back at the facility to go over medication adherence and potentially looking at the wound, weighing the patient. So it's sort of a combination of just a pure telehealth visit versus having the patient come in person. And that's, I guess, related to, and what are you seeing with hospital at home?
Yeah, so I think that that's the case. Well, so to answer Dr. Lewis's specific question, I think that the best asset of in-person, the biggest downside of telehealth, is that sort of formal settling on a decision, making a decision and moving forward on the next step in that decision process. I have found that we tend to do that less well when it's in the virtual platform. Now, hospital home might be the exception to that, but that's I don't know that's because that's more in vivo. It is in vivo, but it's a recreation of the hospital, of the clinic or the hospital setting in someone's home. So I still think we sort of are doing some of those very deliberate decisional steps and approaches in the home environment.
So Dr. Claire has an important issue, and that's talking about telehealth payment parity and how this may potentially impact access to care. And before you answer that, we started doing telehealth at the VA, I think it was 07, 08. And one of the advantages in the VA was we didn't have to worry about how it's going to get paid. So it really advanced very quickly in the VA. We're able to have multiple telehealth solutions. But certainly in the private sector, and what happened with COVID, it accelerated one because people didn't want to see patients and potentially expose themselves. But secondly, CMS and other payers agreed to pay for it. So want to comment on that?
Yeah, so I think there's some pulling back on that generous payment, but not as badly as I expected. I expected it to go back to the way it was pre-pandemic, and it hasn't quite done that yet. So I think that's a sign of why, both on the clinician and the patient side, the high level of acceptance and the pushback against reverting. I think you have to, this is where you want to be creative on your mix of in-person and telemedicine. And there are some value-based payment models. So, I think of chronic care management, CCM is an example of that. And that's, that would not in any way replace the in-person visit. You still need to do the in-person visit, but then the between in-person visit interactions that you have with the patient, those can sometimes then become billable through the CCM and other types of similar value-based care models. So I would say this is an important opportunity to do that. This might be a way to use time-based billing more effectively also, that maybe you just bill for the more time you might spend on telemedicine, and that's a better way to capture some of that. So I think this is an opportunity right now for us to think creatively about the different CMS options that are there, rather than just the standard E&M codes that have typically occurred. I think you're going to run into some issues with being able to get to afford. But it's harder to kind of have multiple rooms all going at the same time. When you have telemedicine, unless your nursing staff is, or your office staff is equipped to handling multiple iPad wait rooms at the same time.
So just to change gears a little bit, there is utilization of digital health in clinical trials. And do you have any personal experience with using digital health and decentralized clinical trials in a heavy Medicaid population that deals with a lot of social determinants? And is that potentially a future pathway to increase the enrollment of underrepresented populations in clinical trials?
I personally myself don't have as much experience on this, though I do have some colleagues who in the county hospital system, they are trying to use this. It's for recruitment, if nothing else, and some data collection processes by using digital health a bit more frequently. I think I think some of the clinical trials companies, they are starting to adopt digital health as just ways of more efficiently doing the kinds of things they normally do. But I'm sorry, I don't as much have experience doing this myself.
I don't see. Oh, I don't have increasing patient portals not factored into our work to expect. So yeah, what the impact on provider workload and how you account for that.
So I think that's where you have to, again, be a little creative on time-based billing. That might be because you can bill for some, if it's during that same visit, you can bill for some of that extra time outside the face-to-face that becomes part of your visit. If you do engage, that's where the chronic care CCM model, the time, there's a certain number of minutes in a month that you spend engaging with that patient or looking at the patient's chart, anything related to that patient. If it adds all that time adds up to a certain number of minutes per month, that could qualify for a CCM payment. So that's not the perfect answer to your question, but I think CMS isn't completely ignorant of this, and they're trying to find ways. I don't always find them to be the easiest to engage with, I'll be honest. It was hard to get the geriatrics clinic to adopt CCM, but some of these things do exist that are worth looking into.
Well, Aanand, I want to thank you for, first of all, being a great collaborator in the past.
Thank you.
I really miss the interaction and working on the research together, especially mentoring surgical residents. Congratulations on a brilliant career and where you are now and what you've accomplished. And thanks for a really great talk.
Great. Thank you so much. I appreciate the invitation, and good luck to everyone.
Thanks, Aanand.
Thank you.